We're going to get started. The topic for today is getting a dementia diagnosis, why it matters, and what to expect. Okay. All right. So the outline is first we'll go over just an overview of brain anatomy and healthy function, the difference between normal aging and dementia, some common causes for dementia, recommended medical and neurologic workup for a person with memory loss, and then the management and treatment plan that would be based on the specific cause for dementia that was figured out, as well as a list of questions that would be helpful for you to ask the doctor. And then we'll end with just some take-home points. And just as a disclaimer, of course, this talk is just meant for information and education, and it doesn't constitute healthcare. And you should always talk to your personal doctor before you make any changes in your healthcare. Okay, so first let's start with how does a healthy brain work? Every area of the brain controls a different function. So if we separate out in this color-coded guide, the various lobes of the brain, we'll start with the frontal lobe in orange. So that's responsible for executive function, which includes problem solving, planning, and organizing. Also responsible for memory retrieval, for expressive language, for motor skills, your behavior, your emotional control. So, so many things, many aspects of a personality. Really, that's all relates back to the frontal lobe. The parietal lobe in yellow, that's the area responsible for touch, for integration of all our senses, for math, for reading skills, knowing the difference between right and left, our body orientation, and our spatial awareness. The temporal lobe in the teal color is for auditory processing, so being able to process the, what you hear in that language, behavior, memory learning, and understanding language. And then in the back, in green, we have the occipital lobe, which is responsible for visual processing and depth and color perception, object and face recognition. And then beyond those four lobes, there's a cerebellum here in purple, which controls balance, coordination of movement, but also cognitive and affective control. And then the brainstem in blue is really all of our automatic functions. So like breathing, consciousness, blood pressure, heart rate, body temperature, digestion, and sleep. And so when you have a person has cognitive symptoms, we could figure out and relate them back to what part of the brain is actually causing the problem. And once we know the parts of the brain causing the problem, we can help figure out what was driving it, right? So in Alzheimer's disease, for example, the parietal lobes and the temporal lobes tend to become affected very early, which is why a person with Alzheimer's typically will have problems with learning new memories and language and being disoriented in their environment, because those are the functions that relate back to those lobes, the parietal and the temporal lobes. So moving on to whether, how do we know if it's not just normal aging, right? How do we define dementia? So there are normal changes that happen in the brain as we get older. So anatomically, the brain volume decreases, especially in the frontal and temporal lobes. The blood flow decreases. And then cognitively, we have less attention, our multitasking ability declines, our speed of thinking declines. But there's many things that really should remain preserved to in the category of just normal aging. And those would be the skills we've learned, overlearned knowledge, our vocabulary, and our memory for faces. So here's a kind of dramatic example of how you could see on the healthy brain on the left compared to on the right, showing what gross specimen of severe Alzheimer's disease would look like. And so, of course, a diseased brain will lead to dysfunction. And again, the areas of the brain that are affected by the disease relate back to what symptoms you would expect to see, especially early on. Dementia is not a normal part of aging, right? So just to go over what exactly dementia means, it's really what we call an umbrella term. Because it in general, it just defines that there's a decline in memory and other areas of cognitive function, and the decline is interfering with independence. So it's not a disease by itself. To go over the first part of the definition first, with decline in cognitive function, this table kind of outlines, what would be the difference between a symptom that matches normal aging versus various causes for dementia. So in the memory category, for example, it's normal to occasionally forget names or appointments or details of an event or something. But in various causes for dementia, the person would be unable to learn and retain new information. for orientation, again, normal aging would be more like occasionally forgetting a date or getting mixed up in an unfamiliar environment. Whereas in various causes for dementia, the person might instead lose track of the month or the season or start getting lost in familiar environments. With regard to language, in normal aging, a person may occasionally develop word finding difficulty, and then maybe if they wait long enough, the word comes back to them, or getting a hint, or something like that, like the word. Then they'll suddenly realize exactly what they meant to say. But in various causes for dementia, instead, the person may have difficulty actually having a conversation, or trouble with simple words, or saying words that aren't actually true words because some of the letters are substituted, or not understanding the meaning of words and being confused in when they hear something and they might reply, what is that? With a noun that should have easily been known. In the category of judgment, in normal aging, a person might occasionally make bad decisions, but with various causes for dementia, a person instead might frequently fall for scams or show examples of poor judgment. And then finally, in the category of performing familiar tasks, with normal aging, a person may occasionally lose an item or miss a monthly payment. But in various causes for dementia, it's more dramatic things you could see, like forgetting a familiar cooking recipe, not being able to operate household appliances like usual, unable to manage a budget that was done easily before, and then just overall thinking about, skills that were known and developed and now have gotten lost. So again, decline is not the same as dysfunction. Decline is expected. As we went over already, there's a certain level of cognitive changes that develop with age, but dysfunction is not normal. And so that leads to the second part of that definition, the decline in independent function. It's important to ask yourself, have the memory loss and other cognitive complaints led to an impairment in the usual function? And so to figure that out, we usually ask about instrumental activities of daily living, which are the harder tasks of everyday life, like the finances, medication management, driving safely, keeping up the household, preparing meals, shopping, using a telephone or cell phone, right? And then then the simpler things, the regular activities of daily living, which include bathing, showering, dressing, using the toilet, being able to physically transfer from a bed to a chair, using the bathroom without having accidents, and then being able to feed oneself. So if a person is developing cognitive symptoms that match more in that second column I showed you, and they're no longer able to take care of themselves the way they always used to, then you start wondering that the person might be having symptoms that fall into the category of dementia. So that leads to the next part, right, which is what actually causes dementia. Because as I mentioned, dementia is this umbrella term. It's not a disease by itself. And so this is an abbreviated list of the possible causes. And Alzheimer's disease is the most common cause. So it could make up to 80% actually of all causes, but it can often be combined with another cause. So really only 50% of dementia is caused by Alzheimer's disease purely. Vascular dementia is the second most common cause, and that's about 10 to 20%. And vascular dementia, there's actually different kind of subtypes of that. A person may have a stroke and then have symptoms of dementia. That's an obvious cause for vascular dementia. But other people can have more of a progressive course where they get hardening of the arteries in the brain, and as that progresses, they could have progressive symptoms of dementia. And then other people might have what I just mentioned, this progressive symptoms of dementia from the hardening of the arteries, but then also have small strokes that didn't have symptoms that were so obvious to bring the person to medical attention, like to go to the hospital. But then they get imaging done and you see tons of small strokes everywhere, in addition to all this other what we call white matter disease. And so there's various different types of vascular dementia, but that's the second most common cause overall. And then mixed dementia, also very common, and that's just what the name implies. It's a mixture of Alzheimer's and vascular dementia. Next, we have dementia with Lewy bodies, important to mention because that's the second most common neurodegenerative cause. Neurodegenerative meaning that there's abnormal brain shrinkage in different regions, and different proteins depositing in the brain that aren't supposed to be there. So Alzheimer's disease, of course, being a neurodegenerative type, and dementia with Lewy bodies being the second most common neurodegenerative type. And frontotemporal degeneration, another neurodegenerative type of dementia. This is worth mentioning because this is actually the most common cause in people under 60 years old who develop dementia. And then finally, normal pressure hydrocephalus, not so common, but important to mention because this is one of the few causes of dementia that might actually be eligible for surgery and potentially reversing the symptoms. So some causes of dementia may require treatment, right? So if we talk again about the neurodegenerative causes, there's not a cure yet for Alzheimer's, dementia with Lewy bodies, frontotemporal dementia, Parkinson's disease dementia, and of course, some other types of dementia. I'm not going to go into detail here, but you get the idea. These all neurodegenerative causes, there isn't a cure yet, but there are some symptomatic treatments that are available depending on the cause. And of course, one would want to know what cause they have because that would help us figure out if a particular treatment was appropriate or actually if a particular treatment should be avoided. Because some medications can actually worsen symptoms in certain types of dementia. Another reason it's so important for us to understand the type. So again, dementia caused by normal pressure hydrocephalus, that actually might be reversible with surgery. When it comes to vascular dementia, that's very important because if a person is having these small strokes or even large stroke, like I mentioned, then there is treatment for stroke that could prevent the next one. So that would be very important for us to know if a person should be on stroke prevention treatment. And then finally, although there's usually one main cause for a person's dementia, there's typically a lot of contributing factors, and each of those factors might be treatable. So even if it's only a small percentage of symptoms that might be improved with treating the contributing factors, that's better than nothing. And that could really all accumulate into helping a person. And so again, so you should just not assume that a person's dementia is untreatable. So how do we figure out the cause of dementia? So here's a list of doctors who evaluate patients for memory loss. So in the primary care doctor category, a person might go to their internist or a geriatrician, who's a specialist for patients who are 65 and older. A neurologist evaluates people for dementia, and that might be a general neurologist or a subspecialist called a behavioral neurologist. And as I mentioned in the introduction, that's what I am, a behavioral neurologist. And then psychiatrists also evaluate people for memory loss. And in terms of subspecialty within psychiatry, a geriatric psychiatrist or a neuropsychiatrist. And then finally, a neuropsychologist, I list on here too. A neuropsychologist is not a medical doctor, but often a person that's on the team in helping figure out the cause for somebody's memory problems. And so the goal, no matter which specialist or generalist you choose to go to, the goal is to get a comprehensive evaluation. Many conditions can increase the risk and the worsening of dementia. And so when I say comprehensive evaluation, what I mean is it's not just a matter of talking about the symptoms a person's having, but to evaluate, what are all the other things that might be contributing that aren't so obvious. And what are the things that we need to think about that could increase risk for worsening of symptoms. So there's some risks that we just can't do anything about. Age, of course, family history, and our genetics. And then by the time a person has developed symptoms, they've already done all the schooling they're going to have done. So educational achievement is a risk, but not one that we could really modify by the time you're getting an evaluation. But then you see on this table, there's a ton of other risks and modifiable factors that are so important. So just to name a few, like in bold, that have been shown in some studies to be some of the biggest modifiable factors: physical exercise, obesity, and high blood pressure. But so many other things, smoking, your any toxic habits, traumatic brain injury, mood, all of our senses, our hearing, our vision, nutrition, sleep. So many things. So when you're getting an evaluation, it's important to make sure that the doctor is going through kind of the comprehensive list, like on that table I just showed you. And some of the ways we do that would include blood work. Anyone who's being evaluated for memory loss, it's typical to have some vitamin levels checked, their thyroid function checked, and then certain viruses and other types of infections are important to look for, because even if there's not any obvious risk factors for those, it depends. Some particular diseases can actually lay dormant for years without a person knowing it's syphilis, for example. So even if a person doesn't have any current risk factors for having contracted syphilis, that's a type of condition that actually could have been lying dormant in the body for decades. Depression and or anxiety, going over an evaluation of somebody's mood, that's very important to do when having a comprehensive evaluation, not only because the untreated depression or anxiety can mimic dementia, but in somebody where that's unfortunately not the only cause, obviously their quality of life will be affected by those mood conditions, and could get in the way of the part of the optimal treatment, which includes for example having an active lifestyle. Medications, that's so important to review when having an evaluation for dementia, because there's so many side effects that can come from prescribed pills and also over-the-counter pills. So for example, over-the-counter sleeping pills that have Benadryl in it, like any of the PM drugs, like Tylenol PM and others, those can actually worsen memory and have been associated with dementia. Overactive bladder pills, some of them also can cause symptoms. And all this falls into the category of anticholinergic. And then pills that are used for pain, or pills that are used for mood, especially benzodiazepines like Klonopin or Xanax or Ativan. Those drugs can really cause a person to have confusion. And in the long term, some studies suggest that there is association with dementia. So reviewing all of the medicines somebody's taking, including the ones that are not prescribed, is very important. So what else would be included in a comprehensive evaluation? Well, you want to go over a detailed review. The doctor will go over a detailed review of what the actual memory and other cognitive symptoms are. And again, it's to try to figure out, do these sound just typical for normal aging, or is it kind of in the abnormal category? And if it's abnormal, what types of cognitive symptoms do they match with? What cognitive domains? Is this memory? Is this language, executive function? And that helps us figure out, what pattern is it matching with when we're thinking about what dementia it could be. You also would get a review of what physical symptoms might be associated, because there are Parkinson's-like symptoms, which we call Parkinsonism, that develop in some types of dementia, but not others, right? So in Alzheimer's disease, it would not be common for a person to, in addition to having their cognitive symptoms, it would not be common for them to have some early symptoms of falls and tremor, or the posture becoming stooped and the shuffling gait. That would not be typical for Alzheimer's, but it is typical for other types of dementia. And then, as I mentioned already, we want to review whether there's any associated mood or personality changes. And a few reasons for that. Some types of dementia can cause changes in behavior, mood, and personality. But also we want to address the needs of the whole person and help improve quality of life. Sleep, definitely important to go over in any comprehensive evaluation. We want to know if there's an undiagnosed or undertreated sleep disorder that can worsen cognitive symptoms, for example, sleep apnea. Excuse me. And then some sleep disorders are associated with certain types of dementia. So for example, REM sleep behavior disorder, which is a condition where a person, normally when you're in the dreaming stage of sleep, which is REM sleep, your body is limp. And so that's helpful, because then when you're dreaming about something, right, you're not actually acting out the dream in your sleep. Right, that could be dangerous. But unfortunately, people who have this condition, REM sleep behavior disorder, that's what happens. Their body is not limp like it's supposed to be. Their muscle tone is not relaxed, and so they actually are, talking or fighting or sometimes could, punch a bed partner or hurt themselves on a nightstand or something like that. So going over symptoms that could match with that condition, are very important because it helps give you a clue as to whether maybe we're dealing with certain type of dementia that's associated with that condition or not. Next, going over the current and former substance use is very helpful because tobacco, alcohol, and recreational drugs all can alter the brain. And if the dementia symptoms are actually due to active alcohol use, then abstinence can improve the symptoms, right? So again, we should never assume that the person's cause for dementia is, they have it and that's it, and there's nothing that can be done, right? What if actually there's an active component that's causing the symptoms, and you could remove that component and the symptoms can improve, and alcohol is a great example of that. Next, cognitive testing, right? So of course, somebody who's being evaluated will undergo some cognitive testing, and the depth with which the testing goes really depends on the type of doctor that you're seeing. So an internist office would be more likely to do one of the more simple memory screening tests compared to going to a behavioral neurologist or a geriatric psychiatrist, where you're going to get more in-depth testing, but it's still kind of in the category of what we call screening testing. And so aside from, getting the certain tests done, the person administering the test, right, needs to be able to interpret the results and figure out, what kind of pattern does this performance fit in? What type of dementia might the performance fit in? Or is it actually a pattern that matches more with what you might expect with only normal aging or depression, right? Now, if we're thinking that it's the performance is really that good that we wonder about normal aging, or we wonder about whether this is depression that's just mimicking dementia, and of course, for some other reasons, then that's when we would send somebody for more robust testing that wouldn't be done in the medical doctor's office, but instead would be done by a neuropsychologist. And that's much more formal. The testing itself lasts a number of hours, and rather than just looking at general score on screening tests like you do with the the neurologist or something, these tests really are standardized for and they account for your age and your education level. So we're able to see, does your performance match where we expect you to be, right? Because a person who is expected to perform at, let's say, a superior level on all accounts, that's different from a person who might be expected to be below average in everything. So a screening test, the person who's superior may perform normally, but for them it might not be normal, right? So that's why neuropsychological testing is really helpful, again, for normal aging, for figuring out depression or anxiety contributors, and in somebody who's really more on the early stage. It's not typically used in somebody who's more moderate or advanced in stage for their cause for dementia. And then, of course, when the neuropsychological testing report comes back, whatever doctor referred for it, they should be able to understand how to reconcile the symptoms with the results so that a diagnosis could be finalized by the doctor. More parts of a comprehensive evaluation. Imaging is considered the standard of care when it comes to a memory loss evaluation. That's because we need to look at the structure of the brain. MRI is much better for looking at structure than a CAT scan, but some people can't get a CAT scan. Can't get an MRI because maybe they have a pacemaker, and so you get what you can. But there's a few reasons why this is so important. One is because we could see signs of old strokes or all that white matter disease I was mentioning earlier, which those would support a diagnosis of vascular dementia. It could also show clues for neurodegenerative causes for dementia. The brain shrinks as we age, that's normal. But if we see too much shrinkage for the person's age, or maybe disproportionate shrinkage in just some parts of the brain, some of those lobes I was showing before compared to others, those can be clues. And of course, you would never get the goal, nobody would ever order an MRI and use that to say, oh, this proves you have, Alzheimer's disease. It's not really used in that way. You don't diagnose a certain type of dementia based on the MRI, but it's one of the tools we have to put all the clues together, say, the symptoms the person's experiencing, their performance in the cognitive testing, and the clues on the imaging. The whole package is what allows us to diagnose somebody with the particular cause for dementia, not just any one, not just any one test. And then the other reason for the MRI is to make sure we don't have one of the other less common causes for dementia, like a brain tumor or hydrocephalus, something that would maybe be surgical and potentially reversible. Other brain imaging studies are different. Instead of looking at structure, they look at function. And so it is common to get an FDG PET scan in people with dementia, but that's not used as a screening tool. That's really once a person's cause for dementia is pretty much known, like we really think somebody has Alzheimer's, or we really think somebody has frontotemporal degeneration, but we want to clarify if this functional scan kind of proves it. And the way it does that is when you get an FDG PET scan, you're injected with a sugar solution. And since the brain uses sugar for fuel, we get to see, does the brain light up normally as it would be expected to, like it's using the sugar solution like normal, or do we see low uptake of that solution, which is a marker for low function of the brain? And what's the pattern of where the function is low? And based on that pattern, that tells us, is it an Alzheimer's pattern? Is it frontotemporal dementia pattern? So a PET scan can be a useful test. And then if somebody has symptoms on the Parkinson's spectrum, and so we suspect a dementia caused by one of the Parkinson's spectrum diseases, then there's other particular types of tests that might be useful. I grayed out the part about specific biomarkers like in Alzheimer's disease, because those are not across the board standard of care. Those are used in more particular situations, like if somebody is very young and maybe their cause for dementia, a lot of the testing has been inconsistent and it's unclear. Those can be helpful. They're not yet really covered by insurance, and so they're very costly. And so if you could get the answer with the more standard workup, then it's not typically necessary. Of course, if somebody's trying to pursue a research study where the drug being tested is specifically targeting a biomarker, then of course those scans are regularly used, because you have to prove that a person has the particular biomarker target that the drug is going at. And then other neurodegenerative disease biomarkers, I think it was just a year ago where I was telling people, no, you can't just send a simple blood test to figure out what somebody has. But actually, I'm not going to be able to say that really much longer, because there are blood tests now that are coming out that can show evidence for what you'd expect in Alzheimer's disease. And so that's not really being used across the board, but that's something that's kind of evolving. Spinal tap is different. There are biomarkers you could look for, different proteins in the spinal fluid that can prove Alzheimer's disease pathology, but that also falls into the category of things that are not done for everyone, more because obviously it's not, it's kind of invasive to do a spinal tap on people. And if you could figure it out without doing that, then it's, just better to not have to put a needle in somebody's back for their convenience. Okay, so after all the tests are done, what should we expect to be told, right? So you've gone to the doctor, you had this comprehensive evaluation in the office, you were sent for some tests like imaging tests, maybe neuropsychological testing, if things were the doctor thought that would be a benefit added to whatever cognitive testing was done in the office, right? So now you're coming back to go over the results, and what should you be told? Well, just in general, are the symptoms consistent with dementia or not, right? And if it is dementia, what's the cause? What's the stage? Is it mild, moderate, severe? And what are the other medical conditions that you have that could be making the dementia worse? The things we went over: mood, sleep, high blood pressure, high cholesterol, diabetes. What are the specific areas that need to be targeted in that person in order to make things better? And then many other questions next, right? So now that we know the cause, what do we do? And so this is a list of other questions that, once you're clear on the disease, we need to have a management plan. So Are there FDA-approved drugs for this type of dementia? And if there are, is it worth the risk, right? Are the particular risks worth the possible benefits in that person? Are there medications or supplements that can improve the symptoms, whether they're, FDA approved for that condition or not? Are there anything that we should be using off-label or over the counter that might be helpful? Are there certain medicines that actually should be avoided, right? Certain types of dementia, like dementia with Lewy bodies, for example, there's certain medications that you would not want to use. It could really worsen the symptoms, like Haldol. So that would be very important to know. And what about clinical trials? Is this something that, based on the particular disease and the stage, should the person consider enrolling in a clinical trial, and where, and, how do you even go about that? I'm thinking about, the future. What new symptoms should we expect sooner rather than later, right? There's certain things that, based on the particular type of dementia, we would expect that symptom to come up now rather than, maybe 5 years from now. And what will life be like even later in the disease, and how can we prepare for that? Other questions should include that you should ask the doctor if they're not going over it with you already, right? Are there lifestyle changes that could help? Like diet, physical exercise, cognitive exercise. Are there supportive therapies that could help that, more formally, ordered with a prescription, like psychological therapy, physical therapy, occupational therapy, speech language therapy, swallow therapy, art therapy, music therapy, right? There's so many things. And so should we be receiving a prescription for one of those or multiple? And which doctors and providers should be on our care team, right? That's important to understand, because sometimes the doctor you're seeing and giving the diagnosis isn't going to be the person that you call when something comes up. So it's important to understand, who should be on my team if they're not already, and kind of what do I do next? What safety measures should we take? That's an important question to ask if it's not being gone over reflexively, right? And the two big examples to think about are driving safety, and what about being left alone? Are there best communication practices that could help mood and behavior? That's a big one. More common in later stages of certain types of dementia. Agitation can develop. And so a lot of times agitation is just triggered by a well-intentioned caregiver saying things in a way that, really ended up, unfortunately, not being helpful and actually was harmful. And so with just tweaking the person's language and phrasing and how they were communicating, you could resolve the agitation. Then you don't have to end up going on one of those medications that were in the let's avoid category, or one that might cause actually worse symptoms in the long term. So yeah, but going over communication strategies is really could be a key area for management. And what caregiver support services are available, right? And what other community programs or resources should be pursued? Those are very important questions to think about. And then finally, how else can we plan ahead? Whether it's living arrangements, do we need to think about moving out of the home into a facility? Can we stay at home? We have a multi-level house, all these types of questions. What about the finances and in general, decision-making, like healthcare proxy, power of attorney, things like that. So these are all kind of the big topics that you'd want covered in a comprehensive evaluation once you're kind of clear on what the diagnosis is, and then and be prepared to ask, let's say, if maybe some of the topics aren't discussed automatically. Okay, so now what if the workup indicates that the cause for dementia has no drug treatment available? Well, I hope you see that no drug treatment is not the same as no management plan, right? From all the things we just went over. And then when disease-modifying therapies do become available or recommended, you'll want to know what the diagnosis is, right? You won't want to be starting from scratch. You'd want to know, is maybe your person has a condition that matches what the new treatment available is at. Next, diagnostic clarity allows for planning ahead, proper expectation management, anticipatory guidance, and then documentation for benefits and services, right? So diagnostic clarity obviously is very important. And then the long list of contributing conditions and factors I went over with you earlier. Though you want to know, what could be optimized to help the symptoms and the course of the disease. So finally, Is this all of this really necessary? And yes, I hope I've proven that. So some take-home points. Do not assume that the memory decline or other cognitive symptoms are due to normal aging, nor that it must be due to Alzheimer's disease and nothing can be done. Anyone experiencing cognitive decline should have a comprehensive evaluation to get a specific diagnosis. And again, that's to look for reversible causes or to identify causes that are treatable, if not reversible, to create a comprehensive management plan, even if not reversible or treatable, and one that optimizes safety and quality of life, and of course, to plan ahead. And then in terms of care coordination, my view, and of course, as being a specialist, I have a bias there, but my view is that a specialist is really best suited to provide that comprehensive diagnosis and treatment plan. But there are so many doctors and care teams that are beyond just that one specialist that are really required for the ongoing management of dementia and all of the medical conditions that affect dementia. So it's really it's really a team effort. And then, of course, community resources are so important for the ongoing guidance and support services. So here's just some logos of the various different groups, that when it comes to, like the first slide of actually getting a diagnosis, and then the big organizations for the various conditions, and home agencies, and dementia coach, and Alzheimer's and dementia care program. So lots of different people who can be included on the team. And with that, I'd be happy to take any questions.
That was great. Thank you. I love that slide of all your partners. I'm like, oh, that's a great slide. Lots of great people on there.